The first line therapy in CLL, the initiation of which depends upon certain criteria that are present. The criteria are evidence of progressive marrow failure, worsening of anemia or thrombocytopenia not due to autoimmune destruction, whether there's any massive progressive symptomatic splenomegaly, massive progressive symptomatic lymphadenopathy, autoimmune anemia or thrombocytopenia that's not responsive to the standard therapy like glucocorticoids, or whether there's any constitutional symptoms like unintentional weight loss more than 10% over 6 months, whether there's any significant fatigue that's hampering work, fever more than 100.5 degrees for 2 weeks without infection, night sweats for more than 1 month without infection. So that's the criteria you need to initiate treatment. So in the initiation of treatment, what you need to look for is the mutation status of this one gene, TP53. That's a major determinant of therapy, whether it's mutated or intact. That determines the course of therapy. So if it is mutated, there's no role of chemoimmunotherapy. There's no role of chemoimmunotherapy like fludarabine, cyclophosphamide, rituximab. So if it is mutated at any age, any fitness, what you can do is initiate a Bruton tyrosine kinase inhibitor like ibrutinib with or without obinutuzumab. And you can give venetoclax plus obinutuzumab. We need to understand this because this is the usual standard care. Bruton tyrosine kinase inhibitor with or without obinutuzumab. Venetoclax with obinutuzumab. So that's when the T53 is mutated at any age, any fitness. If it is intact in the older unfit adult, whether if it is unmutated or not, this is another gene that we should look for, IGHV, whether it's mutated or not. If it is IGHV is mutated or unmutated, it doesn't matter. What you do is give Bruton tyrosine kinase inhibitor with or without obinutuzumab, venetoclax plus obinutuzumab. Whether it's mutated or unmutated, same thing. Venetoclax with obinutuzumab, Bruton tyrosine kinase inhibitor with or without obinutuzumab. So the only place where chemoimmunotherapy is given up front is here in young fit patients where the IGHV is mutated. There you give fludarabine, cyclophosphamide and rituximab with Bruton tyrosine kinase inhibitor with or without obinutuzumab and venetoclax with obinutuzumab. So the only real place where you give a different therapy is in the young fit patient with an intact TP53 with IGHV mutated. There you give fludarabine, cyclophosphamide, rituximab along with the standard drugs. If you're going to order a IHC panel for CLL, that's important because it can differentiate it from mantle cell lymphoma. So in the IHC panel, what you should ask for is CD3, 5, 10, 20, 23 and cyclin D1. What's important is 23 and cyclin D1 because it differentiates it from mantle cell lymphoma. CLL is distinguished from mantle cell lymphoma by expression of CD23 and absence of overexpression of cyclin D1. That's how you differentiate it from mantle cell lymphoma. So that's the IHC panel. In the cell surface markers, what you ask for is kappa lambda, CD19, 20, 23 and CD5, CD10. 19, 20, 23, CD5 and CD10. That's about the IHC panel. Quick word about ibrutinib, because it's the first line drug for CLL. For CLL, SLL, and Waldenstrom's macroglobulinemia, the dose is 420 mg, 420, 420 mg orally once daily. 420 mg once daily. That's the usual dose. It can be used in mantle cell lymphoma, CLL, SLL, Waldenstrom's, and marginal zone lymphoma also. So the main thing is you should monitor for bleeding, infections, fever, cardiac arrhythmias like atrial fibrillation, elevated blood pressure, tumor lysis syndrome, and you should watch out for secondary primary malignancies. You should advise CBCs monthly, assess the baseline tumor lysis syndrome risk, and women should avoid pregnancy while on the drug. Adverse events are neutropenia, thrombocytopenia, diarrhea, anemia, musculoskeletal pain, rash, nausea, fatigue, can cause hemorrhage. It should be avoided in patients with baseline hepatic impairment. If there is a progressive disease, you should look for BTK mutations. Drug interactions can happen with certain drugs like warfarin, CYP3A inhibitors. So you should watch out for that.